I want to introduce the next session, the first part of this second after morning tea break. It's a presentation from the Sex and Gender Policies and Health and Medicine Research Project team. I'm not going to tell you much about it because they're going to tell us about it. We'll be hearing today from Associate Professor Cheryl Carcel, Dr Laura Downey and Dr Sue Haupt. And again, hopefully there'll be plenty of time for audience questions at the end, and so if we could save your questions to that time. So straight into it. Cheryl, over to you.
Thanks, Robin, and thank you everyone for this opportunity to speak today. I'd first like to thank New South Wales Health for their generous funding for this event through the New South Wales Health and Medical Research sponsorship. And I'd also like to thank Professor Robin Norton, Professor Zoe Weiner, and Professor Louise Chappell for their mentorship and sponsorship in this field. And you've been an inspiration to a lot of people, and thank you for moving the dial. And so today I hope I'm going to use some of CARA's emerging trends in the first few slides that I'm going to present to you. And so this is a lady who contacted us a while back now before when our paper was released in 2022. And so she said, you know, last night I saw the media release on my local news and was in tears because the same thing happened to her. So at that time in 2018, she was 45, married with children. She had sudden onset of difficulty reading and writing, as well as she couldn't tell a spoon from a fork. And so she called the ambulance, and she was told that, you know, you're just a tired, stressed out mom, go have a sleep. We can take you to the hospital, but they're super busy. She finally decided to go to hospital. She had a worsening headache, and her stroke symptoms got a little bit worse. So she had her partner drive her to the hospital, and when she arrived to the hospital, she was triaged to the hallway because the ED was super busy, and they had a man who needed attention because he was coding. And so finally, after being in the hospital or in the emergency room for a few hours, she was discharged as having perimenopausal migraine. So you can have some sort of stroke symptoms while having a migraine. But this was her diagnosis on discharge, and given an MRI request to have a brain MRI. And in the outpatient setting, this might take somewhere between 2 to 3 weeks. So the final result was she ended up having a stroke during that time, which was found on MRI. And I guess the reason why I'm presenting this is because, you know, there is that sort of four-week delay in treatment where she could have had immediate life-saving, life-changing treatment. And she didn't get it, and until now she continues to have cognitive issues. And so that was, so this patient is from out of state. And so this was the study that the woman saw out on media that we did, and it was looking at pre-hospital emergency medical service care, differences between women and men who were subsequently admitted to hospital with a stroke in New South Wales. And this was between 2005 to 2018. So a while back now, but still very relevant now. And so we found that there were over 200,000 people hospitalized with a stroke during this period. There was no difference between people being diagnosed as stroke. So there's no difference between women and men being diagnosed as stroke. And just to remember that this is a population of patients who've had stroke. Women were more likely to call an ambulance when they've had stroke symptoms. But the other key findings in this study, and you'll see them on the screen, was that in women who have had a stroke, those less than 70 were less likely to be assessed as having a stroke, similar to that case that we saw earlier. And they're also more likely to be diagnosed as having a migraine, anxiety, or hypertension. And they're less likely to be given pre-hospital stroke care protocol. And why is this important? It's important because in patients who have the fast warning signs. So that's a face, arm, and speech problems. You immediately call 000. You'll be transported to the highest level of stroke care facility in New South Wales. And this means that, again, when I mentioned earlier that you'll be given life-saving, life-changing treatment. So it could mean the difference between being wheeled out of hospital or walking out of the hospital on your discharge. And so delayed treatment in stroke could mean that there are greater consequences for women because they most likely might benefit more from these studies. And so why is this happening? And so we see this, and this is from the Go Red for Women by the American Heart Association. And then we kind of see this, and I think, so the figure on your right is probably enough for the public because there are just too many things to remember if you look at this figure on the left. But this is what the public is taught, if you have face, arm, speech symptoms, call 000 immediately. But in reality, healthcare professionals probably need to learn a bit more that while the first and third most common symptoms of stroke are the same in women and men, and that's what we see here in FAST, it's weakness and numbness. There are other symptoms in women that women can have when they're manifesting strokes, and this can go under-recognized. And so it's not isolated in Australia, and that case study earlier, she was from out of state, but it's also happening in Denmark and happening in the US. So this is a big issue where women are under-recognized in having a stroke. And many of you will have seen this End Gender Bias survey released on the 14th of March, and it's been an eye-opener for many of us. Just to summarize, there were over 2,000 responses from Australian women about their experiences of barriers and bias in the health system. And women, girls, people assigned female at birth, as well as experts were invited. But also specific views from priority populations were sought. And we found this, they were asked what research areas are being overlooked, and a lot of them are, common to women's health or reproductive health or common only to women, but there are also areas here where women might present differently from men, and so that's important to recognize. And we discussed this quite a bit when Cara spoke, that there's sort of blindness in cell animal research, but also human research. And what we really wanted to do was to address these sex and gender bias and blindness. And it started with this paper. This project started in 2017, so a while back now, but it was published in 2020. And really, it's looking at a group of like-minded individuals, and it was at this time it was a group of 8 universities from Australia and the US, all committed to improving sex and gender policies in health and medical research. And within these, so it's open access, so you can get it, but within this paper you will find that there is a set of recommendations, and we've sort of listed it by stakeholders, and some of these has been addressed in our current project now, which I'm presenting. So that recommendation or call to action paper really was about shifting research practice using different interventions that you'll see in the middle here to make sex and gender research more visible. And with this in mind, and with philanthropic funding, we had a collaboration between the George Institute and the Australian Human Rights Institute. And this is actually the last couple of months of our project. So we are at the tail end of it. And it's a big team. There's a few people from Australian Human Rights Institute, the George Institute, and we have Professor Zoe Weiner from Department of Health. And then we have this really important advisory group. And this is a group of people with lived experience, with researchers, academics, and experts in their field, all contributing to how this policy project should look like. And this policy project aimed to look at the Australian stakeholder groups, and thank you, Amy Vassallo, for this grouping. But really, it's looking at all the different research funders, research and educators, mostly the group of 8, publishers and reviewers, research users, and research advocates, peak bodies, and societies such as AMRI. And this project had 3 phases, so I'm going to use a lot of phase words in this talk, and so I'll try not to confuse everyone. But this project had 3 phases. Phase 1 and phase 2 I'll be talking about, and Dr. Laura Downey will be talking about phase 3. So the first part was mapping current practice, and really it was divided into 3 different phases, in where we had a planning forum where we invited key stakeholders that we already knew were working in the area to map out who are the individuals working in the sex and gender policy space in health and medical research. And then we had a survey for stakeholders, and we undertook this study during COVID. So we didn't really have a lot of we didn't have the numbers that we wanted for our survey, and so we performed a post-survey web search to supplement the findings. And this was, again, looking at the whole medical research sector. And so from phase 1, we did find a few barriers and facilitators, and in this barrier, you'll see a lot of themes here looking at lack of leadership. There is issues with terminology. I think we still have, and this was in 2021, 2022, and I think the terminology issue still is present until now. And also a lack of systems and policies to facilitate developing sex and gender policies. And the facilitators mirror the barriers here, and really it's about being supportive, having training and support, having champions of Australian organizations leading the way. And this was the Australian stakeholders who responded to the survey and the survey status. And you'll see that there are not a lot of organizations that had a policy, and that's the 3rd column. But there are a few who wanted to do their own policy on sex and gender research, and we thought that that's something we could really build on, and that led us to phase 2 in building capacity. And so for those who don't know AMRI is the Australian Association of Medical Research Institute. And in 2021, we partnered with AMRI because it represents over 50% of the Australian health and medical research sector. It's non-government, not-for-profit coalition with allied interests. And we approached the CEO, Dr. Sareed Billard, and during that time, they just released their gender equity, diversity, and inclusion strategy. And this actually had 4 priorities, and one of them, the 4th priority, was for addressing inequities in health research. And this really fit in with AMRI's priorities at that time. So we decided to partner with AMRI and perform a democratic deliberative process in partnership with 2 other groups, New Democracy and Gauge Consulting. And this was really a whole 7-step process where we engaged with evidence, we deliberated whether this was the right thing, made a decision, and then went back to look at the evidence again, and finally draft some policies. And in the end, AMRI and the participants of this workshop had to endorse the policy recommendations. And so we had over 30 participants, and you'll see some of the results here in terms of demographics of the group. We had a majority of women in the study. There were more mid-level people, and it was from independent institutes, and there were more researchers. But we had also a good number of staff, and I don't have a lot of time to go through all of the policy recommendations, but I've put in the link there. But really, AMRI, the policy recommendations for AMRI sets the scene for Medical Research Institute. And they're advocating for visibility and awareness of the critical need for consideration, to develop a robust mechanism to respond to ongoing change and complexity, to include, monitor, benchmark, and report mechanisms across its spheres of influence, and will continue to lead education efforts aimed at increasing knowledge and understanding of sex characteristics, sex and gender variables in health and medical research. And so this was a whole huge project undertaken by a lot of people. And really, this work with AMRI is complement to the recent draft policy from NHMRC and MRFF out in consultation today on sex and gender in health and medical research, but also to Medical Journal of Australia's recommendation of the SAGER guidelines for authors publishing in the journal. And I think that's the end of my talk. Thanks, everyone. And I'd like to thank the participants of the AMRI workshop. I know a few of you are here. Thank you for participating. I'd also like to thank Drs. Amy Vassallo and Dr. Sue Haupt for helping with the slides and your contributions to Phase 1 and Phase 2. And of course, Lily Halliday and her team for organizing this two-day event. Thank you, everyone.
Thanks, Cheryl. So my name's Laura Downey, and I was asked to join the team at a later phase of this project for what Cheryl referred to earlier as Phase 3. And so Phase 3 was essentially set up to try and do some research around the economic benefit of better sex and gender disaggregated data. And we know that in health and medical research policy and practice, that having better data ultimately should lead to better health, better practice, and that benefits not only those who have that data targeted towards them and their characteristics, but actually for everyone. The healthier the population, the healthier the economy and society. So economic impacts are wide-ranging. They can be direct impacts, such as interaction with a health service that costs money, often taxpayers' money if it's a public health service. They can be indirect impacts on people's economic productivity, the days that they may take off work when they're sick, for example. They can interact with allied health services, such as psychological support or physiotherapy. And what we wanted to know, or what I was asked to really investigate, was what is the return on investment of better data? And what does this mean for the health of the population and really the health of the economy? How do we quantify the economic impacts of better health, and better health being a consequence of better sex and gender disaggregated data? And this is a really difficult question to answer, and one that I had no idea how to tackle. And so just a couple of years ago, a really important turning point for understanding the economic benefit of sex and gender disaggregated data came in the form of the WHAM report. WHAM stands for Women's Health Access, Movement. Women's Health Access Matters, actually. And so the WHAM report was this fantastic, very lengthy report that took a number of different conditions where there was known disproportionate health impacts on women in comparison to men, and tried to estimate the economic benefit of targeting data towards those conditions. And I think from memory they were arthritis, Alzheimer's disease, and coronary heart disease. And what this report did was build some really complex dynamic statistical models, attach economic costs to that, and come up with this top line figure that for the American public, if you invested $300 million of American taxpayer dollars into women's health research across just 3 diseases, there would be $13 billion in returns to the US economy. And while this makes a really, really nice message for advocacy purposes, and indeed I don't want to trash the report at all, it was a very, very impressive report. As I was reading through it, as a health economist, it really struck me that there was no clear, transparent basis for where these numbers came from. And there were some really, really gross assumptions that were made in terms of what better data would mean in terms of better health and how to economically quantify those benefits. And so I was asked, could I do something like this to replicate for the Australian economy? And actually on doing a bit of reading, I said, no, I can't. I don't think that it's useful to build these huge numbers without having a strong basis upon which they are built. And so what I could do perhaps is take a small case study where we know that there are differences between men and women, and we could look at what is the economic benefit of closing that gap. And I think it's important to note that at this stage we really did look only at differences between men and women because we knew that the data was there, and the whole purpose of this exercise was to look at quantifying the benefit of better data. And so there are huge implications for populations that are not currently covered within this study. But we looked at one example where if we were able to quantify the difference between men and women in terms of the research that we have, how that research led to translation in clinical practice that was targeted at individual characteristics, and what the economic return on investment would that generate. And so that was our starting point. And then I realised not only were there no clear articulation of assumptions in the RAM report, there really wasn't any clear articulation of what the problem was in this space and what activities were required in order to address that problem, and how we would go about economically quantifying the benefits that that would generate. And so that struck me as the most logical starting point. And what our team did was work with a number of different individuals operating across this space to develop a theory of change. And so a theory of change is something that we use often in health systems and social science research, particularly around implementation science, to help us better articulate what is the problem we're trying to address, how are we going to go about addressing that problem, what do we hope to achieve by addressing that problem and produce, and then what are the impacts that we hope to achieve, or at least contribute towards achieving, as a consequence of that program of work. And so in doing this, we really hoped that we could start to bring everybody together on the same page, because in operating in these spaces, speaking with individuals such as yourself, it really became apparent to us that everybody is talking about the same issues that they believe exist in the space, about different ways in which that could be addressed, but there was no documentation in the literature that put this all in one place. And so that's what we hoped to achieve by building this theory of change. And so we undertook a rigorous exercise, given ethical approval by this university, UNSW, to start to put together a theory of change. And as I say, bring everybody on board, put them on the same page. And so we started by doing initial mapping, looking at what was currently published, what was in the literature to guide us. And actually there was very, very little, if any, published literature around theories of change for better data, targeting sex and gender disaggregation and sex and gender characteristics that led to better implementation of health practice, clinical practice, that led to better health and led to generating economic outputs. And so we mapped the literature, found there was very little, but used this to put together an interview guide. With that interview guide, we interviewed around 17 stakeholders that represented either women's health advocacy charities, clinicians working in either women's health or a broad range of different clinical expertise, with those that represented advocacy groups for those with intersex or diverse gender characteristics, those from different organisations that represented policy. And we asked a range of questions around what those different individuals representing their different organisations or institutions felt were the main issues currently in this space, what they would like to see done to tackle this, how they felt they could contribute towards, or their institutes could contribute towards tackling some of these issues, and ultimately, what did they think would be the impact of this program of work? What did they want to see achieved? And so we brought all of this information together and developed a draft theory of change, which I'll show you in a minute. It's a little bit overwhelming, so I'll try and break it down. That theory of change then underwent consultation, again with these groups and a wider stakeholder network of the advisory groups and individuals involved in this sex and gender in medical policies and research project. We then further revised the theory of change, brought it back to a stakeholder workshop, sought additional feedback, and then together put together what I'll show you on the next slide. So this is the theory of change. I won't break this down in each of the individual boxes here, but we do have it available in a policy brief for dissemination at this event. So please do take a copy and take the time to read it. It's also available on our website. But what we really tried to do in this one schematic was capture what are the key problems that exist in the space of medical research, policy and practice when it comes to considering sex and gender. And we found that uniformly there was a recognition that there was a lack of awareness that this is a really important issue, that there was an inadequate and biased incorporation of sex and gender into health and medical research, that there was often exclusion, as Cara already mentioned, of women, but also of those who identify as trans or intersex in medical research. And that has really important knock-on effects for what we can put into practice in clinical practice and what we understand in our policies and how we evaluate those. And so taking these into consideration, we then developed a series of activities that could start to address some of these issues. And they included things like sector-wide capacity building for both understanding this issue as well as incorporating it into practice, whether you're a researcher, a clinician, a policymaker, an advocate, or somewhere in between. We looked at also doing things like developing communities of practice to share best practice and to also encourage engagement in this space. Looking at developing policies for how better data could be produced that incorporate sex and gender considerations wherever necessary. Also looking at things like having monitoring and evaluation mechanisms so that policies that were developed at an institutional or organisational level could actually be monitored for their implementation and approved upon in time. In engaging these activities, there were a number of outputs that we be produced as a consequence, and these included things like a better trained workforce who could adequately encompass sex and gender into their either research, clinical practice, or their policy making. There would be a baseline of reporting on sex and gender and how it impacts certain results and how we could start to unpick those results in terms of intersectionality and other areas of research practice. We hoped that there would also be a generation of policies that guided these kind of activities in practice, and that there would also lead to sex and gender informed clinical practice where necessary. Clinical guidelines, for example, could be updated with that improved data so that we do have clear guidance for clinicians in terms of what to look out for if there was a suspected heart attack or stroke in different populations. In doing this, we hoped the outcomes would really be better research practice, better clinical practice, and healthier people. And ultimately, that if we have these things combined, we have enhanced health, well-being, and economic productivity for everyone. And so, as a researcher, we like things kind of disaggregated, and this helps us, I guess, track pathways to change, as I'll come onto in the economic modelling part, but we also realised that this is not really digestible for a policy audience. And so what we did was also develop a policy brief that breaks down all of that information into something that we hope is more easily understood and translated and implemented into policy. And so again, this schematic is in the policy brief that I encourage you all to take a copy of and read. But again, we just have enhanced health and well-being for everybody at that centre as the ultimate impact that we want to achieve by having better data, better translation, better practice. And then all of the different, you can see, activities in the green, outputs and outcomes that we would like to achieve. And around this circle, we have an evidence translation and implementation cycle so that we continue to learn. The more that we engage in better data practices, the more we're able to translate better data into better research. Better research, we hope, will lead to better health. And then as we're implementing all of these new changes, we're also monitoring and evaluating them and learning from them so that we can continue to learn and change and move towards that ultimate impact. A number of barriers and facilitators were also commonly articulated by our stakeholders, and these include a lack of awareness, accountability, and willingness to disrupt the status quo. And then conversely, the facilitators looking at leadership. And often what we found in the limited literature that we did see is that having people champion this is one of the key things that actually facilitates change. And so having people like Robin, like Cara, like others in this room continually bang on the door of policymakers, of researchers, of all those organisations, and stand up in forums like this and continually bring that message that this is important, slowly does lead to change. And so just a summary of the key messages from our policy brief and our exercise in building this theory of change. We found that there are existing problems in Australia and elsewhere in terms of incorporation or of bias and invisibility and exclusion of those based on sex and gender characteristics, that we need a coordinated sector-wide approach to addressing this, that there's a need for outputs and outcomes of these activities to be monitored, and so we can learn as we continually monitor, evaluate, that leadership is needed, and that change across the sector can impact research knowledge, policy, practice, and clinical care, leading to enhanced health and well-being for everyone. And so once we had this theory of change, it was a bit easier for us to start to conceptualize, well, could we now track one of these pathways to impact and put some economic costs and benefits on that in order to start to very, very, in a small way, answer that question, what is the economic return on investment of better data? And so we went back to the research team and to Cheryl and others and said, do you have good examples where you know that there is a disparity that we could start to capture? Well, what is the value of better information to close that gap? And so we took the example that Cheryl mentioned earlier, where in New South Wales, the state that we're currently in Australia, there is a statistically significant difference in accurate diagnosis of stroke between men and women upon presentation to ambulance. And that difference actually was very small. And what we found when looking in the literature is that difference is up to 10 times higher in a number of other countries, including America. So that if you were a woman, you were about 3% less likely to be accurately diagnosed as having a stroke in comparison to a man when you present to ambulance. So this difference was very small, but it was still significant, and it was still a gap that we thought would be interesting to quantify in terms of the economic cost, or conversely, what would be the economic benefit of closing that gap. And so what we did was build an economic model to essentially look at closing that gap. So answering the question crudely, what is the economic benefit of treating women like men, or diagnosing women as accurately as men are currently diagnosed? So we didn't advocate for or indeed investigate the impact of any intervention. All we did was look at how can we quantify the impact of closing this gap using the data that is currently there for men in terms of that initial point at which people present to ambulance, in comparison to the status quo, which is how the accuracy of women's diagnosis at present. And so you can see in what this is called a decision tree, at the very first decision node, we have women aged under 70 years presenting to an ambulance. We know from looking back that all these women did actually have stroke, and so what we're really looking at now is diagnostic accuracy. In the first arm on the top, we put women through the model with the values that are currently attained by men. So this is a diagnostic accuracy, which is still quite low actually, around 35%. And then we compared that to what is the diagnostic accuracy of women at present, which is less than 30%. Once you have moved into this node of diagnostic accuracy, everything else remains the same. So you receive either usual care plus IVT, which, as Cheryl explained earlier, is the gold standard of care. It's very, very important, and there is a very important time window to this treatment, which is thrombolysis. So if you do not receive this in a timely manner, you may fall outside of the window upon which it's clinically appropriate to be delivered, and therefore your outcomes are going to be much worse. And so what we were looking at, the core assumption underlying this model was, if there's a delay in diagnosis, there is likely a delay in timely treatment. If there's a delay in timely treatment, there's highly likely to be a delay in knock-on effect in terms of your functional outcomes and your morbidity and mortality. And so how can we attach both economic costs to the outcomes of this, as well as looking at the economic benefits of closing that gap? And so you can see here we have, as you move through, you get diagnosed accurately or inaccurately. You then receive usual care plus IVT, or usual care by itself without this IVT, knowing that only around 20% of the population are actually eligible to receive this. And there's also an important time window component within this. And then once you have received that, you move into a score of functional status, with 0 being your life is perfectly normal, you have no ramifications of your stroke, and 6 being death, with everything else in between a functional gradient of how disabled you have become as a consequence of that initial stroke. From these states, you then move into having no future stroke, to having a recurrent stroke, or to dying. And again, you cycle through the model, going through these different stages for the lifetime horizon of those within this model. And so in looking at that, we then looked at what costs can we attach to these different states. And we took a societal perspective, recognising that often what happens in economic evaluation is that we only take a health system perspective, which means we only take into account the costs borne by the health system. And this means that those costs would be interacting with clinical care physicians, with hospital, inpatient and outpatient, sometimes with pharmaceuticals if they're covered by health systems and health insurance schemes. And we took a societal perspective, meaning we also took into account the costs borne by the individuals. And these are things like having to upgrade your home with certain equipment if you are severely disabled after your stroke, in having to interact with a physiotherapist to regain your functional ability to walk, for example, or grasp objects, in also seeking psychological support for those who have trauma after experiencing a stroke. And also indirect costs, including productivity loss, recognising that depending upon which functional state somebody enters after having their stroke, there may be substantial impact on their ability to contribute to the economic workforce and to generate personal income. And then our primary outcome measure was a quality adjusted life year. So this is something commonly used in economics. It takes into account the quality of your life as well as the time in which you spend in that state. And so it's a bit more nuanced than just a life year gained, whether you are able to improve the or elongate the life that you lead, but taking into account the quality of the life that you're actually living in then. And so what we found is that women in the men's benchmark arm, so this is a reminder, is just women who receive the same diagnostic accuracy as men currently receive upon presentation to ambulance, accrued health gains of 0.32 QALYs. So very crudely, this is around 4 extra months in a better quality health state, with a cost savings of around $16,000 per person. And so importantly, this is a societal perspective, meaning that this $16,000 is borne by society. It's not just taxpayer money going directly into the health system, but that also close to 50% of this money is individual savings from their lost productivity, from costs that they had to provide themselves in terms of extra modifications to their home, for caregiving for spouses if they were affected, or other family members. And then we looked at what does this mean for Australia, knowing that at the national level there are around 6,000 women a year under 70 who present with stroke. Of those, around 20% are eligible for IVT. And then we looked at that number being around close to 1,200 women. It would result in 376.96 additional QALYs gained per year, and cost savings of around $18 million to the Australian public. And so as a reminder, this was a very, very small difference, indicating that Australia is actually doing very well in terms of adequate, whether adequate is the right term or not, in terms of identifying stroke in both men and women, but there is still gains to be made because women are statistically significantly less likely to be accurately diagnosed. And again, this is actually 10 times higher in the States, where there was a 35% difference in one study in terms of accurate diagnosis of men and women. But even this very, very small difference accrued actually quite substantial cost savings, 18 million, actually it's closer to $19 million on an annual basis, by really doing nothing but better recognising stroke in women. So the flyer that Cheryl produced earlier showing that the signs of stroke in women are slightly different to men, having those educational promotion campaigns for both individuals experiencing stroke as well as ambulance staff, paramedics, hospital staff. No intervention is required necessarily beyond just better educating those in the community and in the paramedic and medical community around recognising stroke in women. And so the policy conclusion from this was that the health gains and cost savings resulting from closing that gender gap in stroke care could hugely benefit Australian society as a whole. If we have healthier women, we have healthier society. We have people that are able to be back in work quicker to generate their own income, but also contribute to Australia's economic productivity. We have less burden on the health service in terms of both outpatient and inpatient care. If you are treated with IVT earlier, you're less likely to stay in hospital longer, you're better functional outcomes much quicker, and you're substantially reducing the burden on the health system as well as the individual. And so to conclude, what we really found is that we attempted to put onto one page what are the common issues in this area when we talk about better data for better clinical practice and better translation and what that means in terms of economics. And we were able to, in our own very small way, quantify just a very small gap in what that would mean for Australia, recognising that we know that there are sex and gender disparities in access to healthcare and indeed in disparity in health between different sexes and genders, and in being able to close that gap across the wide range of conditions that we know that there are those differences, there are huge economic gains to be made in Australia. So I'll pass on to Sue.
I thought to start with a little background. While I was working at the Peter MacCallum Cancer Centre in Melbourne as a senior research fellow, I uncovered that sex influenced outcomes in our preclinical cancer models. These findings set me on a pathway of discovery to explore genetic and molecular mechanisms involved in sex differences in cancers. And I'd just like to thank Cara particularly for emphasising the long non-coding RNA exists and the sex chromosomes in the context of autoimmune disease, because we looked at the flip side and we studied those in cancer and found that they were extremely influential there. I'd be happy to talk about that if anyone after. And so I became an advocate for including sex considerations in research. And just 1 year ago, I was delighted to join the team and that's working towards advancing sex and gender equity in health and medicine. From the 3 phases, as presented by Cheryl and Laura, the need and desire for a centre has been emphasised. So to advance this vision, Robin championed the process of embarking on a series of consultations with potential stakeholders to the centre. And today I'll talk to you about the efforts, our first efforts to engage 2 key focus groups, researchers and health-related community groups. So first, I'll introduce you to our engagement with researchers. So partnering with AMRI as a peak representative body linked us to 50% of the Australian Medical Research Centre, which was fabulous. But we are also interested to engage beyond that umbrella. And to do this, we leveraged our networks, sent out extensively across the country invitations to participate in consultations. We had 174 people register, 130 attended, across a series of consultations with researchers from around Australia. Post-consultation, we asked people to engage in a questionnaire comprised of 13 questions, and around 71 people responded, which was about 55% of the attendees. We had responses from Victoria, New South Wales, ACT. We also had from Western Australia, Queensland, and we'll be really working to engage people from other states, South Australia, Northern Territory and Tassie in the future. I'd just like to start with two key highlights. So from the researchers who were responding, we had 90% who identified that they were studying sex and gender. So we were targeting a great audience who were engaged in this. The other great response is from 69 people, 58 who are researchers plus another 11 who are practitioners not primarily involved in research. We had 99% of people wanting to join a centre, which is absolutely fabulous. Among the responders, women predominated, and I think this is likely due to their acute awareness of the need, but we also had men and non-binary people, which is really important in these preliminary responses. We have strong engagement from key partners in the centre, TGI, the George Institute, Deakin, New South Wales Uni, from where the Australian Human Rights Institute is based. But we also had engagement from numerous other institutes, which we're very excited about. In terms of work areas, public health dominated, but we also had great involvement from people doing clinical medicine and science research and also basic research. And then in career stage, we had quite a spread from early, mid to advanced. People were asked to indicate which areas they undertook their research, and I've mapped this as a benchmark of our initial interests. So just to explain the approach, each circle with a letter in it indicates a primary interest of a single researcher, but many people had multiple interests, and so I've indicated those additional interests by a non-lettered circle, and I've linked those to the primary. And I'll give some more specific examples as I work through that. So we clustered interests together. We see that we have great interest in women's health, men's health, gender diverse people. We also have people studying sex differences and their mechanisms and processes, and we have a group there working on First Nations people's health. So they're the broader groupings, but we then also have more defined topics. So there we also identified a really interesting clustering. So we have, for example, on the left, we have psychology, psychiatry, behaviours and mental health. We have people looking at diversity, equity and discrimination. We have people working on diet and health, including metabolic disorders. We have people working on cancer. We have people working on reproductive health, gender-based violence, health economics, health education, a broad spread. But the exciting thing is that having clustered them together, we see that there's drawn convergence of interests from different general groups. So if we take one of the examples from women's health, for example, we have someone there working on reproductive health, but linking down to ageing, which clusters in with somebody who's working on diet and health. We have people working on cardiovascular diseases, linking up from the psychology, psychiatry, behaviours and mental health, linking down from women, across from sex differences, mechanisms. And we can see these patterns emerging across this whole mapping exercise. And this mapping highlights the scope for wide cross-disciplinary, cross-institute engagement within a focused topic hub where sex and gender are the centre of the convergence. And we can see that the centre can provide this facilitating platform for this to occur, which is really exciting. So the second step that we engaged in was a series of consultations with community groups and people with lived experience, also sometimes referred to as consumers. And to indicate their involvement in this, I've put the mapping for the research into the centre, and I've clustered the different consumer groups around that. So you can see on the top left, we have people working in the area of women's health. We have people a little lower working in the area of men's health. We have the community of practice, queers, trans and intersex from the University of New South Wales. We have some more specific groups looking at cancers, heart disease, diabetes, eating disorders. And we also have marked up there the Gunamana team, so that means heal, and they're First Nations people stemming out of the George Institute, and they're going to be undertaking a series of consultations with First Nations people, because involving First Nations people fundamentally across this centre is absolutely crucial to achieving our vision. And of course, we've got Amory there, who we're delighted to have partnered with us. So just to give you a brief summary there of what we've found from this, we've found wide interest from researchers across many disciplines to be part of this centre. We've got genuine engagement from community groups, consumers, and people with lived experience who have a great desire to join the centre. We've got extensive enthusiasm for a centre that fosters links between multidisciplinary members for mutual benefits. I'd just like to finish with an acknowledgement slide. So for the George Institute team, thank you to Robin, Cheryl, Kez, Christine, Mark, and of course Laura, who presented today, from the Australian Human Rights Institute, Louise, David and Lily, who I'd especially like to thank for a huge effort getting this launch off the ground. From the Deakin, we have Rachel and Severine, who's with us today. I'd just like to thank everyone who participated in the consultations and responded to our questionnaires, and a special thank you to also Digila, who was very involved in facilitating all the consultations and also getting this meeting together today. So thank you very much. So I finished there. Now the floor is open to questions. Questions for me, for Cheryl and for Laura.
So guys, thank you so much. A huge amount of work's gone into that, and really appreciate what you've done. But now, we've got more to go, and I know we've got lunch later after that. So I'm very pleased now to introduce our next session, a panel where we'll hear from researchers across the country, some involved with the George Institute, some involved with Deakin as our partner in the new centre, but others from across the country working in other institutions. And this is fantastic that we have brought together a diverse range of people working in a diverse range of research topics. Moderating the panel today is Prue Torrance. It's great to have Prue joining us. Prue is the General Manager at the National Health and Medical Research Council. She has extensive leadership experience in science and research policy and programs, as well as having held senior public service roles in corporate governance and finance. Of particular interest to today's symposium, Prue, with others, has been instrumental in the development of the NHMRC and MRFF's forthcoming statement on sex, gender, variations of sex characteristics, and sexual orientation in health and medical research. So it's very apt that Prue chairs this panel today. Thank you, Prue, and to the panellists who will be coming up to the front now.
Thank you very much, Robin, for that introduction. I'm Prue, the General Manager at NHMRC, and I will shortly introduce all of our panel. But before we do, I have been reminded to say a little bit more about myself, although Robin's already covered quite a lot of it. But I'd like to talk just a little bit, I suppose, about the origins of the statement that we are shortly to publish. And it is hard to pinpoint the moment of origin. There was a lot happening over 2020 in particular. That was the point at which the ABS standard was released, and of course the point at which that MJA piece with a kind of call to action, which included a call to action to research funders, was released. But I will give credit to Morgan Carpenter from Intersex Human Rights Alliance and Nikki Barth from LGBTIQ+ Health Australia, because they were doing a round of meetings with people in Canberra, standard kind of meetings that you'd have as advocacy groups, and they came to meet with us. And at the time I was leading the research quality and some of the ethics work at NHMRC. And one of the first questions they asked is, what are you doing about the ABS standard? It's out. There was a lot of community consultation in developing that standard. We would like to see it implemented. So that certainly was one of the impetuses for taking forward a project. And so where we're at now, a couple of years later, is we are very close to releasing the final NHMRC MRFF statement on sex, gender, variations in sex characteristics and sexual orientation. The purpose of the statement is very much around equity and around health equity, because health and medical research is the evidence base on which we design our healthcare and our health policy and our health systems. So you don't get equity unless the evidence base reflects the needs of the population. It's also about co-design and community involvement in health and medical research. But as funders, NHMRC and MRFF, I really have an opportunity here to use our power as funders to drive that 95% of researchers, getting them involved and on board, to pick a line from this morning. So one of the important things that the statement does is for all research funded through NHMRC and MRF in the future, that it should consider sex, gender, variations of sex characteristics and sexual orientation at all stages of every research project. And importantly, it endorses consistent definitions and classifications, and in particular the ABS standard, although it does recognise circumstances where you might vary from those definitions as needed. The further kind of communication and implementation, including how these things will then play out in what might be needed in grant applications and assessment of grants, will follow. The important thing is to get the statement out there. It provides guidance and a series of kind of policy questions that people can ask us. They're planning their research as they're undertaking their research, as they're undertaking analysis, and as you're preparing for publication. So right through those stages. And I missed the co-design at the beginning, but it's in there, definitely. So that's kind of what NHMRC is doing to support all of this work. But what I heard this morning in the presentation is there are so many more nuances and levels of details and an evolution and a journey that it needs all the players in the system. And so we need the researchers and the community to also take forward this journey, which I think is a nice segue to introducing the panel. I would firstly like to start, though, with acknowledging an apology. We do have a last-minute apology from one of our speakers who's unable to come, but I would like to acknowledge him, Mr. Robert Monaghan, a descendant of the Bengali and Gumanjari nations, and his research, which would have been very interesting for us to hear about, is focusing on identifying the barriers and enablers for Aboriginal men accessing culturally appropriate health services. And particularly in relation to the treatment of STIs and bloodborne viruses. So yes, it would have been very interesting to hear from his research, but I have to offer his apology. So now, to introduce the panel, I will say, you've got their bios, but I'll say just one or two interesting things out of each bio to give you a bit of a sense, and then I'll ask each member of the panel to introduce themselves in more detail, or how they would like to introduce themselves, and to tell us more about their research. Now, I haven't got this in the list that you're sitting, and I'm struggling with the fact I picked up the wrong glasses off the table this morning, so I can either read or I can see you, and I don't have, thank you, Claire. That's nice big print, I can read that. So, to start from that end, moving forward. Associate Professor Claire Arnott is a cardiologist at the Royal Prince Alfred Hospital, and also leads Australia's first women's heart clinic. She's also the program head of the cardiovascular division at the George Institute for Global Health, where she leads several national and international cardiometabolic clinical trials. So bridging that gap between clinician and researcher. Keeping going with introductions, Dr. Bridget Haire is a senior research fellow at the Kirby Institute at the University of New South Wales, so right here. Has quite an interesting history as former president of the Australian Federation of AIDS Organisations, amongst other things, and is currently researching in the areas of research ethics, public health, human rights, and particularly in HIV and other bloodborne infections, sexual health and emerging infectious diseases. It's quite a lot. Helen Keane is a sociologist, Professor Helen Keane at the School of Social Sciences at the Australian National University. Helen and I have a great pleasure of having been in the Centre for Women's Studies together 25 years ago, and it's a pleasure to reconnect. Her main research interests are around drug and alcohol use, including the gendered aspects of drug and alcohol use. And then we have Dr Stephen Kerry, another sociologist at Darwin University. I think we should all put these on our essential reading lists. Dr Kerry published in 2009 a book called Are You a Boy or a Girl? Exploring the lived experience of intersex Australians. And then in 2018, Trans Dilemmas, a study of the health needs of trans and non-binary people living in the Northern Territory. So I think they're the summer reading list for us. Thank you. And is currently researching, which is interesting, intersectionality, Buddhist, queer Buddhist. Sorry, I've lost it on this line. I had it on this one. You will tell us a lot more about it, I'm sure. And Professor Severine Lamon, ARC Future Fellow within Deakin University School of Exercise and Nutrition Sciences, and interestingly is looking at some of the sex differences around skeletal muscle physiology. Dr Lea Merone, a medical doctor from the UK, now at James Cook University, and I believe at a hospital, I saw, yes, Cairns Hospital as well, and looking at public health, gender and sex differences. So that's the brief introduction of our speakers. But I'm now going to ask each of them in turn, and we will go in the same order I have just introduced, to expand a little bit further on your background and why you're here, just briefly. But really what we'd like to know is what's your area of research, and what do you think is kind of the biggest sex or gender challenge you're finding in your field of research as an introduction? So Claire, can I ask you to start?
So I don't think there's anything more exciting about me than what you presented. So I'm a cardiologist, and I lead the cardiovascular program at the George, but I'm a clinical cardiologist, and I suppose got a Churchill Fellowship in women's heart disease and brought that back to Australia and started Australia's first women's heart clinic. I think we're going to talk about that in more detail later, but I suppose I'll make the comment that my patients are why I do what I do, because there are far too many patients that I see where they suffer from conditions, and again we'll talk about this later, but something like spontaneous coronary dissection, where I can't tell my patients why what has happened. I can't give them evidence-based treatments, and I can't tell them how to prevent it happening again. And so, you know, stories like that really very much empowered me to look at sex differences in heart disease. And you know, as I said, we'll speak about this in more detail, but I would like to make the comment that, you know, I feel very inadequate that when I speak about this, I'm not talking about the spectrum of sex, and I'm not talking about the spectrum of gender, because for a lot of the work I do, we don't have those data, and as cardiologists, we're always a bit behind. So I'm very much hoping that I'll be invited back in a decade, and when I'm invited back, I'll be able to present those data for the 10 years of the centre. But that's me.
Okay, thank you. Well, I guess I work at the intersection of sex and gender and how they impact on infectious diseases, particularly around HIV. So HIV is really the sweet spot because it's in the centre of all of the things that I do research on. And in this kind of work, you can't make assumptions about the way that sex, sexuality and gender align or don't align. That you've got the whole culture of the way that people identify. You have these systems that are, I guess, gender is a system that is complex, that is dynamic, and that is unstable. And it is changing now, it's changing around us. When you say that it's unstable and it's dynamic and changing, that doesn't mean that you don't take it seriously. And so if I can give you an example of some work that I've been engaged on recently, it's around actually a clinical trial that is looking at an intervention for sexually transmissible infections, and we're trying to target the people who are at highest risk of these. Those include gay men, men who have sex with men, and trans people who have sex with men. And the minute you look at that, you're involved in all of this complexity, because one of the things we need to know is how people are having sex with each other in order to assess their risk. And you can't make assumptions about what genitals people have, what genitals their partners have. And so needing to actually write sensitively put together surveys that are recognising people's gender identity, and that are also looking specifically both at their genitals and what their genitals are doing in association with what their partner's genitals are. And so we might be looking at men who are having sex with their front holes, women who are having sex with their penises, people who are having sex with their gender diverse partners, and working out ways that we can actually structure our surveys to honour the way that people are seeing themselves, to respect their practices, and also to make sure, I'm sorry, I can hear my microphone doing funny things. I'll just kind of jiggle it a little bit. It just feels a little bit dirty in itself, but sorry. But to make sure we're asking people the right questions, we're actually capturing the data that we need to understand what it is that they're doing sexually. And so I guess I see this as being a really, really important project. It's important ethically, it's important culturally, it's also important medically to be understanding the ways that people are using their bodies and how that works with the way that they are understanding and communicating their gender, both to us as researchers and more broadly than that. I'm also asked to talk about the COP cutie. Do you want me to do that now, or should I wait and let other people talk about their primary research first? Yeah, thank you.
All right. So Helen, would you like to tell us about the social
Thank you. Well, that's a
aspect?
hard act to follow. But I am a sociologist who primarily works on drug and alcohol use and the social and cultural meanings of that. I guess there's two answers to the question of like, what is the biggest challenge? I mean, there's a broad answer, which I think we've already touched on today, which is the issue of acknowledging and recognising difference without sort of reifying it and solidifying it. So, you know, every time we talk about men and women, for example, it's important to do that, to acknowledge differences, but we're also sort of reproducing these categories. And I've done that in my own research. So I think, you know, that's an ongoing challenge. In relation to drug and alcohol use in particular, I think one of the big challenges is the really extraordinary resilience and persistence of stigma related to drug and alcohol use. And I know alcohol is a drug, but this is how it's talked about. But I think that tells us something already about how some forms of drug and alcohol use are seen as normal and socially acceptable, and other forms are demonised and criminalised and punished. And that does track along with structures of inequality and discrimination, such as gender, sexuality, race, and so forth. And there's lots of examples of that, but I just finished a project on alcohol, violence, and gender, and how they understood in relation to the nighttime economy. And one thing we found was a real sort of lack of engagement with masculinity and norms of masculinity as a factor in these forms of violence. So the focus is a lot on alcohol, and the assumption is that alcohol produces certain forms of behaviour. But as a sociologist, you know, I'm interested in how those behaviours differ according to social and cultural norms. And one other example, it's a bit depressing, it's drug education in high schools. I have a colleague, Adrian Ferrugia at La Trobe, who is doing research on drug education, and it's really disappointing to see that even in the 21st century, there's kind of gendered norms around sex, around reputation, which are reproduced in these education materials. So, you know, the aim is to kind of reduce harm of drug and alcohol use amongst young people, which is a noble aim. But in doing that, you know, there's ideas around, you know, like the worst thing around intoxication for young women, for example, is, you know, the possibility of reputational damage around sexuality. So I'll leave it there. Thank you.
Okay, Stephen, what do you think is the biggest issue in your research?
Well, I guess I'll recount. So I did my PhD 20 years ago, and when I say 20 years ago, I get really surprised that it's been that long since I've been doing it. So I looked at the social identities of intersex Australians, and certainly their relationship with doctors, medical professionals, and their parents in decisions that they might have made. And then I just finished a few years ago another project on trans and sex gender diverse people in Northern Territory. So looking specifically at what were the health needs of trans and sex gender diverse people in the Northern Territory. And currently I'm working on a project looking at queer Buddhists or LGBTQI plus Buddhists, and looking at the relationship between the two identities, I guess, and how being queer within a Buddhist community might impact upon their practice and their lives. And I guess one of the things I reflecting on that question is when I guess queer people are presenting themselves to healthcare professionals, they're often don't get much further than that identity of, saying, especially if someone who's new, they're trans, and from then on, their medical professional only ever any form of further activity in terms of their actual health needs is always going to be couched in those terms. And a lot of people I did speak to in the Northern Territory did speak about how they often have to spend a lot of time, a lot of energy, a lot of mental energy, emotional energy, educating before they can actually get any healthcare. And there was a lot of self-advocacy and lots of mental energy going into making sure that what they're going to get was, appropriate to their particular needs. So a lot of my reflection is that idea of understanding that, there is a lack of understanding of that diversity, but also there becomes this almost obsession with trans. So some people spoke about when they told their doctor they were trans, the doctor was, okay, we're all on this, we're going to help you with trans. So they just didn't hear. And my personal experience, I remember a few years ago, I mentioned that I was gay at the time, and we'll get you an AIDS test. It's like, where does that come from? You didn't even ask me if I'm sexually active, I have a partner. There was none of these pre-questions. So I guess that is a lot of the difficulties with healthcare, is that they may think, okay, you're that's it, I'm going to treat you. They sort of overwrite everything else that goes on.
Thank you. And we could return to that topic later to perhaps explore what's the role of research in creating more inclusive health practices that recognises the identities that people want to be recognised by, but actually treats the health holistically as well. Yeah. Okay, Severine, it's your turn.
So I'd like to say that I probably bring a different angle and perspective when compared to what we've just heard, because I like to see research as a spectrum, the same way gender is a spectrum, and I sit at the very, very fundamental end of the spectrum. So my days are filled with cells and animal models, and occasionally human participants. And the reason why I came to this broader topic of sex differences, I think there are two of them. The first one is that I was trained as a muscle physiologist, and the muscle is actually the second most sex-biased tissue in the body, and it's only preceded by the breast. So, okay, there's something there. But the second thing is when I started to do a literature review or to teach basic muscle physiology, I came across statistics showing that in muscle physiology research, only 6%, and that's about 4 or 5 years ago, only 6% of all studies published in the muscle physiology field in the last decade included a female group. Wow. So we've got this massively sex-biased tissue, and no one's actually studied the sex differences and the implication. So sitting at the very fundamental end of this research spectrum, I'm aware that my own research, I won't probably see the impact, or rather the translation, should I say, in my lifetime. However, I'm passionate about good research practice, and that's where I saw my opportunity. I love good science, I love good research, and from what I could see from just a brief scope of the field, is that everything we knew about muscle physiology was derived from male-only studies. How in the world was this going to be translated, even at the most fundamental research, to female muscle physiology? And this is where my interest stemmed from, and I've since expanded this field to multiple research questions, and the most important one for me at the moment being male and females age differently. Aging is massively impacted by how well you maintain your skeletal muscle. So what do we have to learn from the sex differences and the way our muscle ages, and about how it impacts healthy aging in males and females, which, as you know, are only constituting a growing proportion of our population.
And Lea, I'm going to add one more fun fact about Lea, because she finished her PhD in androcentricity in medicine, which sounds like an absolutely fascinating topic in 2022. But please.
So, to give you the background to what led me into my research, I'm a medical doctor in the UK. I started working as a junior doctor in 2011. And in my second year of being a junior doctor, I was working in a little hospital in North Yorkshire. And I'd started to notice some comments before this from doctors that were quite gender-loaded and that were making me a bit uncomfortable. But the day that was really consolidated for me, I was carrying the emergency pager for the surgical wards, and it went off, so I did my little run across the hospital to find out what was going on. And there was a young woman of about my age at the time, just about 24, 25, on the floor of the patient bathroom having a grand mal seizure. So that's your typical what you think of when you think of a seizure, muscles seized up and shaking. So there was a team of us. We stabilized her, got her into bed, and I went off with the more senior doctor, who was a senior registrar, close to consultant, to look through her notes and find out what was going on with her and what might have caused that. They were doing traces of her heart and blood tests and things. And so we got her notes out, and we found out that she'd been admitted with abdominal pain, so, you know, not really that related to a seizure. And I said to him, "What do you think caused her seizure?" And he said, "Oh, that wasn't a real seizure. That was in her head. She was faking it." And during stabilizing her, we'd put a nasopharyngeal tube up her nose. It's a tube that maintains the airway. Her jaw had clamped. It often happens in a seizure. We couldn't get an oral airway in, so we put this massive tube, which is about the thickness of your finger, up her nose, and it goes right down the back to keep the airway open. She hadn't flinched. So as he's telling me he thinks it's in her head, I'm standing there not confident enough as a brand new doctor to say, "I think you're wrong." But that was when the pattern was being consolidated for me. And then I unfortunately became unwell myself later that year. And despite being with a doctor and being a doctor myself, I had real trouble getting doctors to listen to me and to diagnose me, to the point that I actually got really, really, really unwell and ended up spending a month on a chemotherapy unit, having blood transfusions to try and get me well enough to have chemo. And so once I came out of all of that and actually recovered, and I got to Australia and I started noticing the pattern again, at this point I was like, well, what's going on here? So I started my research looking at the background and looking at the history of medicine and medical research, and finding out, as we all know, that most research has been done on men. It's androcentric, and then just applied to women. So I looked to see where the state of that was first in Australia. Then I looked to see how any gaps translate onto the medical school curricula and see if people are actually being educated about this, which I knew myself they weren't, but formalizing it. And then to see how this impacts on the experiences and outcomes of women patients. And I think the reason why I've given this story is because the biggest issue is the one that still stands as far as I'm concerned, which is the dismissal and the disbelief and the stigma of the medical profession towards particularly younger women patients, and as we heard earlier with the younger stroke. And certainly whenever I'm talking about my research and giving the findings over, there are some doctors, usually women doctors actually, and this is anecdotal, who come and thank me and say, wow, that was brilliant. I either knew about that or I didn't know anything about that at all. And the men tend to not listen so much. And I think as a woman researcher, researching women, again, that's another barrier in the medical profession with the stigma that we have. And recently I was supposed to teach med students about this topic, and the male dean of the university decided that it was too radical. Because, you know, the idea that women and men are different is very out there. So that is the reason I did the research, the reason why I'm doing my next PhD, and the issue that still stands.
We'd all like to say that was a surprising story, but I don't think it was to anyone in the room. So I also want to touch on the topic of resistance and how we might overcome resistance. The story we've just heard is a story we hear quite often of also things like even where you can get sex and gender differences on the curriculum and in the professional development programs, men don't turn up. If that's in the title, they don't turn up. So there's a kind of cultural issue of accepting it as everybody's business, everybody's problem. So I have two follow-up kind of themes or questions for the panel, and then I'm sure all of you have got lots of questions you're burning to ask as well. So I'm going to pose both questions because we'll respond to one and some or the other. So I do want to follow up on inclusive. How can we use research to be more inclusive both in our research practice, but also then ultimately to have more inclusive health policy, healthcare, health systems, and what does that look like? And are there risks, just picking up some of the comments, that actually some of the inclusive practice can itself lead to further stigma or discrimination, and how might we manage those? So, you know, small question. And perhaps this might be a time to talk about your community of practice in response to that. So I will go to you first, but just to give the others some thinking space, the second question is around that question of resistance. And I would be really interested in any stories about resistance to the research findings, and any lessons you might have for the audience of how we might overcome that, which is probably a bit too big a ask, but I think we'd like to hear some stories about what you might have experienced so we have an understanding where we might go. So I'm going to start with the community.
Thanks, Prue. And I think about what is important about the community of practice. So our community of practice is called the Community of Practice for Queer and Trans People and People with Variations of Sex Characteristics. And the acronym is COP-QTI. So if you want to look us up, just UNSW COP-QTI for QT. We don't just say queer, trans and intersex people because that creates this impression that they are the same kind of group, whereas we recognise that intersex is quite different to being queer and trans. So intersex isn't an identity, it's a kind of biological category. So we formed this community of practice last year, and when I say we, I want to shout out to my academic co-leads, Karen Drysdale, Christy Newman and Anthony Smith from the School of Art, from the Faculty of Art and Design, Andy Kaladelphos from Law and Justice, Aditya Joshi from Engineering, and Brooke Brady and myself from Health and Medicine. And what our aim was we're people who have been working as advocates and researchers in this space around inclusive research practice. And I guess it starts with words. It starts with trying to use the right language, but words and connections. So it starts with words, but it's about actually trying to form the right connections with people to work out what it is that you are trying to communicate. So what our community of practice does is we provide advice to researchers across UNSW about inclusive practice and about the implementation of that as well, about the implementation of national standards like the Australian Bureau of Statistics standard. We also provide training to higher degree researchers about how they can better include sex and gender and variations of sex characteristics in their research from the ground up. Also how they can form the relationships with community groups if that's what's going to be necessary to do that work. And I think Cara made this point really importantly. We are also looking at developing interdisciplinary research clusters and also providing a forum for people right across the university to come together to deliberate and to debate, because we understand that no one of us holds the right answers, that we need to work together and to be listening to each other and to our communities to know the right ways forward in the research that we do. And so we've formed this kind of collective. We try to work together in a really cooperative way and to be as involving as we can be with the university. So please do watch out for our events. We're going to be quite engaged in this centre for sex and gender, obviously, and it's an incredible privilege to be here on this panel with these amazing people with their wonderful stories about the work that they're doing. So thank you for the opportunity to talk about that.
Good plug. It also is a good example of actually using research as a model for how inclusive practice looks like, and that can then be applied to other areas. Would anyone else like to comment on the inclusive issue? Yeah, Lea?
Yeah, so I guess my answer to transect both questions is firstly, get them while they're young, get them while in university, while they're not fixed and influenced by culture and hidden curriculum. And then the second thing for I come at things as the angle of a disabled woman quite often, just for that caveat, but trying to make workplaces more accessible and inclusive, and indeed research spaces as well. So allowing some flexibility for people with chronic disease, making things, this is excellent, by the way, having the subtitles as a deaf person, so useful, thank you. Amazing how that doesn't happen most of the time. So really sort of making the spaces safe and welcoming and encouraging people and doing outreach to minority groups to say, hey, you can do this, and sending out role model representation and saying, look, this is within your reach, and look at the work that we're doing, which will improve things for the issues that matter to you.
Steve?
I find doing research on gender diverse people, often there's a pushback from people. They want to know, well, what am I going to get out of this? What is it? Why am I giving you and all the other 10,000 people who's interviewed me their emotional labour? And so research fatigue, I think, is really important to understand for a small community, that small communities that probably do get over-researched. That may be the buzzword at the moment, so they'll get lots of attention. So how I approach it, I've certainly been doing it all my career, is while I have great books, I wouldn't go buy them. Email me and I'll send you free links. Because I don't get royalties, so I'm not... Yeah, I have to publish books, I have to publish in journals, but for me it's putting together a booklet or something really casual that I can just give to participants and give to communities that they can use. So if they have to advocate for themselves, they don't have to actually do it. So read this. So they don't actually saves them that time. And when I started doing the research on queer Buddhists, I actually got that straight away. Is this something we can use? Like, well, actually, this is what I do normally. This is what you'll see. All the participants get a summary of what everyone says. Firstly, so all the participants know what everyone else has said after it's been de-identified, etc. But also, I put together these booklets that they can use, and it's all about acknowledging those elements of the emotional labour that people are giving for their experiences, and can they then use it? It's great having conversations. As academics, this is what we do, that's our job, that's what we get paid for, but also acknowledging the community needs something that's going to be digestible for them and how they can use it in their communities, their doctors, whatever it might be. I find that's a great way of really selling the research as well, acknowledging that we aren't just doing it to get information, we want to give something back. And if you prioritise that in discussions, I think that you're going to get more people saying yes to doing research and being interviewed.
Not especially on this one. I'm looking forward to the next question.
Oh yeah, I just want to follow up from that excellent point, which is I think, you can get into the habit of assuming that inclusion is always beneficial to people, and that's not always the case. There are over-researched populations, and
you know, I completely agree that the female body and women, you know, are under-researched in some ways, but I don't know if any of you know the book by Stephen Epstein. It's called Exclusion. Or is it called Inclusion? I can't now remember, one or the other. And he actually critiques, he's a historian of medicine in the United States, and he actually critiques, or at least challenges the idea that, for example, women have been excluded as research subjects. And he sort of reveals this whole awful history, really, you know, for example, of the history of gynecology and research on enslaved women as, you know, really formative in that discipline. So I guess, you know, we need to think about inclusion into what? And so on a more positive note, I think in terms of, you know, resistance, and I would say this because I'm a qualitative researcher and I'm a sociologist, and I think, you know, it's really admirable to kind of have fantastic kind of objective scientific evidence. But the power of a story, I think, can really shift people. And I'm thinking, you know, Cheryl, of your presentation, how you started with one particular story. And, you know, someone said just now, oh, this is anecdotal, as a sort of negative thing. And I get that, like, it's really annoying when, you know, someone says, well, my uncle's cousin, you know, did this and it was fine. Like, it's super annoying. But I do think the anecdotal, the story, can really capture people, you know, and move them, because it's about emotions as well as facts. So I think, you know, if you want to move people, sometimes going to those stories like you did, Cheryl, I think can be very effective.
Oh, sorry, I'll make one comment then. Sorry, I thought we were going to go into another question. So look, I mean, for me, you know, what I can't remember who on the panel said, but the comment about it being relevant to all of society. So I work in women's heart disease, and you know, I'm always kind of giving talks nationally and internationally to a room full of women, and you know, I kind of always start with, where are all the men? Because we all know that when you invest in women's and children's health, you invest in the health of a community, and that what you get back in terms of growth, economically and from a societal perspective is so very important. And so I think when you talk about inclusion, I think it's about getting everyone to come along on the journey with you, and for everyone to understand how very important it is. And I know in women's heart disease, for example, I work as a cardiologist, and the profession is 85% men. So if I really want things to change in the world of cardiology, I need 85% of those men to also want it to change as well. And then for me, the next step is, well, how do I get that message across? And for me, it's data. It's data, because data is so very powerful. You can talk about things, but until you have data that you can present, powerful, very important data, it's really hard to get people to come along on the journey, as well as personal examples, which are also so very important. And so, you know, in the world of women's heart disease, again, I'm using male and female, and that is in so many ways problematic, but you know, the data that I have, we know that women have poorer outcomes in heart disease than men, and it's multifactorial. So we know pathophysiology is different, we know risk factors are different, we know primary and secondary prevention are different, and it all contributes to adverse outcomes. And you know, to what Cara said, this, you know, pathophysiology is really important. Coronary dissection happens to women at certain points in their life, 85 to 95% women. And we know that hormones are very important. So it's the leading cause of an infarct in pregnancy. So we know that, you know, spikes in progesterone are very important. But similarly, there's a lot of bias and multi-sectionality and health systems and societal roles that also are very important in why we have adverse outcomes for women. And Cara, I know you spoke about different symptoms for women who present with heart disease, and there's absolutely studies to suggest that. There's also studies to suggest that's not quite true, but what is true is that we treat patients in different ways, and patients respond in different ways. So they feel that they have less power to talk about certain symptoms, or maybe we're listening less, or maybe we're interacting in a way that, you know, certain patients don't feel comfortable. So look, I know that's a really verbose way of saying it, but I think that we have to bring everyone along in the journey if we need to be inclusive, because everyone needs to want things to change.
I feel the need to add an anecdote just off your story there. I was talking to my teenage daughter about the differences in heart attack symptoms in men and women, but I talked about the differences for women, and she just turned around and said, "Why are you saying women are different? Why don't you say men are different?" Oh, that's good. Let's hope the whole generation thinks that way.
And look, if you'd like a wonderful anecdote, and again, this is not male and female, but I deal with a lot of women, young women who've had heart attacks. So coronary dissection is a lead example, but not the only one. And I was speaking to this wonderful woman who'd just given birth and then had a heart attack. And she told me the brilliant story of the day that she had the heart attack. And it went a little something like, woke up, severe chest pain, sweating, nauseous, all those kind of classic symptoms. But she made her 2 children's breakfast, got them off to school, packed their bags, cleaned the house, and then popped off to the hospital. Now, again, I'm overlaying with so many societal things. I mean, there are many families. I grew up with a family where the father made the lunch and so forth. But the point that I'm making is we have to consider that there are so many complexities to individuals' lives when we think about how they may present or respond, and that directly relates to their outcomes. A delay in presentation of a heart attack directly correlates with adverse outcomes.
I just wanted to make a quick point about one of the key ways that we actually get data about what is happening to people is, of course, through clinical trials. And there was a fantastic research letter in JAMA this morning that said, among other things, that if you search clinicaltrials.gov, the biggest database for clinical trials, to try to find trans people in it, you can't. So the way that data is recorded, in this, the big clinical trials database that, that everybody uses, we can't see whether trans people were involved in that. And I think that just points to the level of exclusion that comes from not collecting the right data and from not actually displaying it in the right ways in databases. Because I'm sure a lot of clinical trials would have collected the data, but it's not being centrally collected, and so you're not actually able to see that. And so how people should be treated, how do you know? What does that mean for a trans person who is, facing a cancer diagnosis and is trying to work out what the best treatment might be for them?
Severine,
Yeah, I wanted to speak to the topic of resistance a bit, and following up on something that Claire said, but also something that Lea said. So I get to speak to a lot of researchers as part of my work, and they can be very junior or very senior. They can be PhD students, but I'm also the National Secretary for the Australian Physiological Society, so I get to interact with all these physiology professors. And something I've found, and to your point, you have to take them young. So I've started a group within my university. It's just a small female physiology and performance group, and we get enormous traction from the kids. So honor student, master student, PhD student, they love to come along to learn about female physiology, to learn about how include sex and gender consideration into their emerging research. And then early career researchers have been interested in, after that, they are lost to the cause because they've already established a research program, right? On the other hand, I get to speak to the physiology professors who have been enormously successful with research funding in their life, and they see absolutely no reason to change whatever they are doing. And these are the same people that tell you, oh no, I don't do bioinformatics because we've never done that, so it's irrelevant. So we don't do female or sex-specific research because this is not how we used to do it, and it's never been a requirement for me to be successful. So I'm surprised that when it comes to resistance, no one's brought up the idea of funding, because I believe that to bring these people in, we have to make them understand that this is not enough to be successful anymore. And listen, your next NHMRC, MRFF, and hopefully ARC comes to the party at some stage, grant, you're just not going to be successful if you do not adhere to our policy and guidelines. So in my mind, it's not the way it should be, but I think it's the path forward. It's one of the ways it will be. And only this way will we bring everyone to the party. But I also agree with that. This generation will self-select at some stage, and hopefully the young and emerging researchers are much more aware, or will be much more aware of sex and gender considerations in their upcoming research. And I think that's a great objective for us in the centre and something to look forward to.
And Severine, I 1000% agree with you, and I think it's kind of the carrot and the stick, right? And, you know, saying to people, okay, you won't be funded if you don't consider this, or you won't be published. But it'd just be really amazing to see if that needle moves. You know, we've spoken about journals having certain requirements, and, you know, without naming names, there was a recent publication in one of the top journals of a drug that probably everyone wants and no one can access out here. You know, at the moment, that was 85% white men. And that was top journal, you know, very high impact, contemporaneous, 85% white men. And I sat on an advisory board and I said, how did they get through? How is this possible? How are you possibly going to extrapolate your findings to our population? Because it's not relevant to so very many of us. And it was kind of, oh, we did our best. So, you know, are things really going to change? And I don't know if anyone knows the answer to that, but I'm just not so very sure that funding bodies and journals are going to do that.
I believe that tackling the problem at the source, and here the source or the roots of the problem is money, because research equals money, right? So I'm deeply convinced that if we make progress at that level, the rest of the research system will follow. Well, I hope so, but you're right. It has to be everyone. It has to be the publishers. It has to be universities who grant seed funding. It has to be universities who or institutional board who approve ethics applications. Everyone has to come to the party, but I really think that the money is key.
I'm going to be a little controversial as well on top of that, so do forgive me, I apologise. But I find that still at the top, it's mostly dominated by middle-aged white men. And while that is still the case, we won't make headway because that's the demographic that don't listen, that it doesn't affect them. I think you said so yourself, you know, if it doesn't affect them and it's the way they've always done it, and it doesn't affect their success either. So it's a win-win, and I'm finding in a lot of spaces that that's the case. It's very still middle-aged white men dominating.
Yeah, you're right. Yeah, absolutely. But I think I would like to just comment on NHMRC initiative for at least taking that step, because you have to start somewhere, right? And we've got examples from internationally, especially North America, where they now have about 10 years worth of data showing that a change is happening. It's slow. It's not as fast as it should be or as they wanted it to be, but it is happening.
Hi there, I'm Tej, pronouns they, them. I work at ACON, which is the AIDS Council of New South Wales, as part of the Pride Inclusion programs. And I have the pleasure of working with a lot of health and human services organisations that are on the journey to see what they can do to help with LGBTQ health. And some of those are pharmaceutical companies who are really looking at how they can use advocacy in the space of clinical trials and protocols to actually see that dial help move as well, because they're finding that quite often the regulatory bodies, you know, may have boards which are cis white men, you know, or they're not seeing the interest because of the international conversation doesn't happen. So what do you see as a way that we can start to get, I guess, more movement in that place, where we're starting to address protocols and regulations to inspire that?
It's really just building the conversation about all the multi-pronged attack we have to have. Is there anyone who would like to reflect on that question?
I think getting the data, so actually using the ABS standard is going to be useful, and trying to insist that that happens. So it not just being a kind of optional thing. With any luck, if the census actually gives us some data on, you know, the sizes of our communities, that would be magnificent. That sort of data is always going to come with limitations, because with respect to sexuality, you know, one person in the household is going to be answering for other people, and with all of the limitations that contains. But I do feel like data is the start, particularly if you're talking about trying to change the TGA.
Thank you so much. My name's Kate Womersley. I'm from the UK, and I've got a question for Lea. So I'm also a doctor, and what you described very much resonates with my experience. and I also had the misfortune of being unwell in that system. But I think the worst discrimination I received was actually from women. And so whilst I absolutely recognise that there are these biases baked in that male doctors perpetuate, I think there are female doctors, women doctors who also contribute to that. So I wonder if you have any reflections of how the system perpetuates a sort of a gender bias that exists outside any one individual, and what we might be able to do to educate, as you say, the next generation better.
Yeah, that's an excellent question. And first of all, in terms of the bias in terms of patient care, yeah, that's pretty equal, men and women, like yourself. Actually, probably the worst one I had was a woman doctor. I think to address your question, I think first of all, education and addressing the hidden curriculum. I think role modeling, because I think another problem is because the system, it's not the people, it's the system, and it's the hidden curriculum. It's the fact that all of our research has been done on men. It's the fact that translates into your guidelines, your policies, your university curricula. So as we're going up and challenging this very comfortable status quo, we need to be turning around and helping the next generation of women up to get up to those levels as well, to spread the word more. So yeah, I think the biggest thing is education, advocacy, and really addressing that hidden curriculum. There's actually some great work going on through the Royal Australian College of Medical Administrators, RACMA, Gillian Farmer. I don't know if anybody's familiar with that name, but she's doing work, it's called A Better Culture, and she's doing work across the medical field, including, I co-chaired the Women in Medicine reference group. If you wanted to give me an email, I can get you involved in that, but essentially the idea is to change the whole sort of toxic culture that there is in medicine, because there's lots of bullying, sexual harassment, power balances, hierarchy issues, and racism and sexism as well. And so they're really doing some work to address that.
Can I jump on just with bias? I mean, it's a brilliant question. I suppose the comment I wanted to make is that bias goes beyond just what happens with medical professionals. It's very important, but we all have bias, and I think it's important that we acknowledge that bias, but I think it's just, education is so important. So, if I give, again, cardiologist, women's heart disease example, and the example that I gave you of my patient, we know that when a woman has a heart attack, it will take her longer to get to a hospital than a man. And there's a lot of factors. There's making school lunches, but there's also the fact that women often don't think that heart disease is relevant to them. They have that inherent bias that has been, layered on since they were born, that's in the media, that's in everything, that it's the middle-aged man who gets heart disease. So there's already a delay to presentation. When they get to hospital, then there's, as you said, there's doctor and systems things. So there'll be a delay to a woman getting an ECG as distinct from a man. There's a delay to diagnosis. And then when they're having a heart attack, there's a delay from diagnosis to cath lab and definitive treatment. And then a woman's less likely to get evidence-based therapy. They're less likely to get cardiac rehab. So I suppose just making the point that if we really truly want to affect change, we need to look at the bias at each point. And understanding that each of us has a bias. And I mean, that's a heart disease example, but very much listening to what you said about someone who's trans who walks in and says they're trans but, has an earache. All of a sudden, straight away, the bias is about, them saying they're trans versus that's not what I've walked in here for. That's not what this is about. So I think we all kind of need to be able to be aware of our own personal biases and understand that we all very much have them.
I think also to add another layer onto that as well is to acknowledge that these biases ripple throughout society. And in terms of the medical bias, one experience that I've had personally and with the women in my research is women then ending up gaslighting themselves because they've been told so much that there's nothing wrong with them, I had patients who literally say they are gaslit in all directions. And to use a personal example, I did it to myself only recently. I hurt my back preparing for the cyclone up in far north Queensland, told myself it was all in my head and it was absolutely fine, spent weeks doing yoga and nothing more to try and fix this back, then had a scan for a completely different reason, which picked up a fractured vertebrae. And that's the thing, it resonates through populations and through internet forums and things, so that bias doesn't just stay contained, it ripples through.
We are now literally eating into lunch, and that's not a pun. But I think we're all keen to hear more. Do we have any more questions from the audience?
Hi, my name's Kate May. I'm a Health Promotion and Communications Consultant and Associate at Common Cause Australia. My interests really sit in public persuasion and communications and how we can frame health issues to get more supporters and get people on board. Really acknowledging what Claire said, that often when you're talking to a room full of health people, you've already got a lot of supporters in the room. We're not necessarily persuading or talking to the audiences that maybe we want to shift. So I'd love to propose a little scenario and see what the panel says. But imagine that today this room was filled with people from just the general public that maybe don't know much about sex and gender in health and medicine and may not think it's an important thing to address. I'd love to know what the panel would say to try and explain why this is important and to get them on board.
I might just start with having seen some of the consultation material we got when we consulted on our statement, is that even within the medical profession there seems to be a bit of scepticism about the importance of the definitions and separating them out, as well as in the community. So there certainly is resistance that is hard to tackle. Would anyone like to tackle that question?
I would start with wanting to say and get agreement in the room that everyone deserves healthcare. Healthcare is for everyone. We all deserve the best care. No one should be going, presenting to a health facility and not being treated in a respectful and professional and effective way. And that unpicking sex and gender is one of the ways that we can start to make things fair. And I guess I would also try not to make people feel bad for being who they are, but to try to recognise that we are, mostly generous and good people who actually want the best for other people, and to try to work with that, if that makes sense, in your scenario.
As a more fundamental person, I actually find that it is a great conversation starter. And Sue and I took a Uber together this morning to ride to Melbourne Airport. And the Uber driver started to make conversation with me and asked me, are you away for work? Where are you going? What are you doing? So I gave him the 1-minute pitch. And within 5 minutes, he had a very clear, very well expressed and thought opinion about why females and women should be included in health and medical research. And that was a fantastic experience, and it's not a unique experience. So in my mind, this is a topic that people relate to because everyone is concerned, absolutely everyone. And this driver told me, if this happened to my wife or to my mother, I would be horrified. And I'm like, yeah, but this is what is happening. And in 5 minutes, I had this guy who I had never talked to before, and I had no idea what his background was, engaged in the topic. So I actually think that it's not that hard. And I think it's Cara who was saying, you need a good stat or good fact. I didn't need any of those. I just told him, do you know that women, for example, often misdiagnosed or diagnosed late in hospital? I was very vague, very generic, and he went like, bam, is that true? Well, if this happened to my family, I'd be really upset. So in my experience, it's actually a really good conversation starter, and the general audience is very happy to contribute simply because everyone can relate.
And he's going to tell everybody he goes into his act.
Yeah, exactly.
I have a response. I don't know if this quite gets to your concern, but I've discovered, I also teach gender studies at university, and I've discovered that everyone is interested in masculinity. Just slightly annoying because men are interested in masculinity, women are interested in masculinity, gender diverse people are interested in masculinity. But I find that talking about masculinity can be quite a good way of engaging people who might think that they're not interested in gender because they see gender as a synonym for women. And they think that gender means women and that hasn't got anything to do with me. So I think talking about masculine norms, how masculinity impacts on health, health outcomes, both in what we might think of as positive and negative ways, can be a kind of conversation starter.
I think it's also just, really good science. Like if we want to find new treatments, new interventions to the benefit of everyone, then we need to consider sex and gender. And, I do clinical trials and, I can tell you that there's not a man who benefits from being analysed in a cohort of men and women. You might miss a very important finding that is of great relevance to the man or to the woman. So I suppose the point that I make is, in a world where everyone's hearing about precision medicine and, how they want, a specific therapy that is targeted to the colour of their eyes and the breakfast that they had, well, this is the very basics of that is the fundamentals of sex and gender, and it's not just to the benefit of certain minority groups, it's to the benefit of all of us.
I'm waiting for someone to suggest more schmick videos like the WHO ones. Thank you, Claire. Well, I think there was another question at the back there. Yes. Oh, and being too generous and giving away the mic, but thank you.
Hi, my name's Peta Forder. I'm from the University of Newcastle and I'm involved with the Australian Longitudinal Study on Women's Health. And just in terms of the work that we do there, it obviously encompasses women from the age of 18 upwards, but we're also looking at the children of the women involved in our study as well, so that's going down to the age of 0. Just really interesting talks and observations from everyone. When we're talking about intersectionality, I was also wondering about the impact of age, because we're talking about getting more people involved, and one of the things that you notice is people get involved with their health when they're sick. They don't know when they're becoming sick. Young people don't advocate for their health. They're not taught what to advocate for. I'm just wondering, in terms of having that gender balance but also incorporating age into it, in terms of being proactive and knowing how to speak for your own health, knowing how to advocate for your own health, and being able to be confident to talk about your own health with your practitioners, because you'll go to a GP, it may or may not be, the person may not be a woman doctor or a male doctor, but just that interaction in terms of young people taking agency for their health, recognising when they should prioritise their health and being able to advocate for that. Is there any comments about that?
Oh, look, it's an excellent question. I suppose, again, I'm going to give you a cardiovascular answer. But I work a lot, and I can see Amanda Henry here, in hypertensive and metabolic disorders of pregnancy. And, we know that women who experience these complications at pregnancy are at markedly elevated cardiovascular risk later in life, and not that much later. And the paradigm of care a decade or so ago was no one even let them know. And I once had a discussion with a male obstetrician who said, why would I tell them when you can't change it? And so we've done a lot of work about understanding that there are very important time points and pivotal time points, and sometimes at very early stages where you can alter a disease trajectory. And so education is so very important. So we do a lot with women in the postpartum setting about understanding when is the right point to give them that information, for them to understand their risk factor, to understand what's important from a primary prevention perspective that's relevant not just to them, but to their entire family. And so we definitely use that point very early in a woman's life to help inform, educate, institute primary prevention, and hopefully kind of empower them for that kind of the rest of their lives.
Thank you for that question. One of the things that made me think about was a consultation that we held for a research project that was in queer Aboriginal young people in the country. And so this was in rural New South Wales. And what was amazing there was that young people were quite able to articulate things about their health and what they needed, and especially around young women and their reproductive health. But the barriers that they faced to actually getting to see a professional, there was basically only one person that they liked going to, and that person charged a whole lot of money. And so I think actually being aware of, GP co-payments and things like that in rural settings where basically access to health depends on the amount of money that you have. One of the really positive findings in that was that most of the young people felt pretty good speaking to their parents or speaking to their mothers. But actually getting from talking to mum or someone else's mum about what's going on and getting to see a professional, there were just so many barriers in the way there. And so I think recognising how very inequitable our basic health system has become in terms of just getting into general practice is important.
We need to break for lunch now? Yep. So please join me in thanking the panel.
Thank you to all the panellists and Prue for moderating. I think you see there's huge diversity in our geographic spread with our researchers and the types of research that people are doing. And I felt that you've actually raised a lot of the issues that we're going to talk about tomorrow about why we need the centre and what the centre can do. I just think one point to make a comment on, and I know Zach Seidler will be talking about this tomorrow from Movember, that men are often disadvantaged as well, and it's perhaps not come out here as much in the panel that as we should do, but a Centre for Sex and Gender is also about improving the health of men and boys. So, but I'm sure we'll talk about that again tomorrow. So look, this does bring to the end our session this morning, and I'll be sending you off to lunch very shortly. But before doing so, I really, again, want to thank these panellists. I want to thank our team from the George, and I feel a bit like that adage that, it's family hold back when you've got the family inviting people for dinner and the family have to hold back. And I apologise to our team because you didn't get a chance to have a whole lot of questions directed to you, but I'm sure others will come up to you over the next couple of days. And of course, Cara, thank you so much for your presentation that really set the scene for where we want to go over the next couple of days and indeed the next few years. I would like to briefly just thank all the team who've been involved in the planning for this morning's session. A range of colleagues from the George Institute, the Australian Human Rights Institute and Deakin University. These are the three partners in the centre moving forward. I'd also like to acknowledge the financial support of the New South Wales Department of Health and our anonymous philanthropic donor who provided the resources for the Sex and Gender Policies project that the team presented before. But also acknowledge our supporting partners, the Victorian Department of Health, the Association of Australian Medical Research Institutes and our communications partner, Women's Agenda.